And it's my pleasure to introduce my friend and colleague, Dr. David Cremonesini, who is a consultant pediatrician in Dubai. He has been working in pediatrics for over a decade, both in the UK and in the UAE. And then he saw the light and went back and did a master's program in allergy at the University of Southampton before returning to Dubai, where he's working at the Medi Clinic and doing both consultant pediatrics and allergy. He did his dissertation on the management of cow's milk allergy in primary care. And I think, speaking very strongly for him, one of his strongest endorsers is Professor Karina Venter, which I think speaks very highly of his expertise. So without further ado, David.
Thank you very much, Stuart. And thank you for the organizers. Thank you, Professor Mohammed, for inviting me today. And I have a nickname for you. I think I'm going to start calling you Prince Andrew, because today, despite all the worry this morning, you kept your calm and you didn't sweat. So I'm going to talk about, and my title is to non-allergists as well, but I'm hoping there are a few online because I look around and not so many here. But I'm going to talk about interpreting food allergy tests, talk about cases where I do food allergy tests, and hopefully share some experience to help with your practice. Now, we don't do questions where people can sign it in the session today, but this question I would have liked to have had. I don't want any answers at the moment, but hopefully by the end of the talk, we'll all get this right. But I think, how you define food allergy is key. If you're going to test it, we need to know what food allergy is. And my question is food allergy an adverse reaction due to a specific immune response on exposure that's reproducible? Or do we diagnose food allergy from a blood test that's high? And I think this is key when we are looking and interpreting blood tests. So let's take a case we might see in clinic, especially if you're a pediatric allergy doctor, but similar for adults too. So we've got a 7-month-old girl who was given scrambled egg for the first time, and parents report that she developed a rash on the face, swelling and vomiting, and vomited after 10 minutes. She was brought to the ER, was given Zyrtec, wasn't in anaphylaxis, and the next day the rash had gone. So as a doctor, generalist, allergy doctor, we've got to decide maybe what's going on. And of course, if we saw the child, we might get more of an idea, but we're relying only on the history often. Here's a child, obviously, with urticaria. So, but the history is very suggestive of IgE-mediated food allergy. Why? First of all, the symptoms appeared quickly. And this is key. When we're taking a history, trying to determine if the child has food allergy or not, the symptoms should happen almost always within the hour. They say maybe 2 hours, but certainly within the hour most commonly. Then we've got the classical symptoms here. We've got swelling. We've got a rash that's itchy, and there's vomiting. So clear there's an abnormal response to this protein. We have no history of previous ingestion, so it's not that this child has eaten the food before, or this recently, which would be a warning bell that maybe this isn't. And what's important, the rash is gone by the next day. So if the rash continues, that's not food allergy. But we still need to do a test because the parents may get the food wrong. That scrambled egg may have been made with some peanut oil or something. So we need to do a test. So what test would we do? Now, this is a key factor, I feel, in Dubai, because what we're seeing, especially from pediatricians and general doctors, is not what I would do. Because what we are seeing, at least I see in my clinic, is doctors were in this sort of scenario doing a food panel, not just the food in question. And this child had a food panel, and this was the result. So the egg is high, 43.3. So we've got a history with egg, we've got a positive blood test, egg allergy. But with the food panel, we're seeing other positive test results. Milk, 0.58, wheat, soya, peanut. And the problem with this test is the interpretation. And too often we're seeing sometimes doctors then saying, you need to avoid all these tests. So the mother was now told to avoid 9 foods as well as egg. But the mum said, but my child was eating yogurts, had had it many times. Why am I avoiding that food? And the key thing is that the presence of IgE does not mean allergy. And as we said, allergy is defined as having a reaction. And a positive blood test only proves sensitization. And there's this great study in the US looking at the problem with food panel testing. So this was looking at 800 patients in a tertiary pediatric referral center. They reviewed all the patients there, these doctors, and challenged these patients. So out of the 800 encounters they reviewed, 35% had a food panel. That's really high. But when they reviewed the history, they felt only 30% of those that had a food panel actually had a history warranting an allergy test in the first place. And then of those that had a food panel, when they brought foods back because the patient was advised to avoid based on the food panel, 90% tolerated that food they brought back. So that gave them a positive predictive value for food panel testing in an unselected population, 2.2%. But this is a population referred to a pediatric center. So if we're talking about general population, when people are being seen by general pediatricians, that potentially is even lower, and that's 2.2% is low enough. Now we know there's lots of studies showing how lots of people are sensitized, but they're not allergic. And this study looking at the difference, so 16% of egg are 16% are sensitized to egg, but when challenged, 9% were allergic. Peanut, 30%. So we need to be really careful. So the key for me when we're looking at testing children with suspected food allergy is the history. That gives you the most important information. And then test the foods that the patients are saying to you, I think my child or I am allergic to this because this happens. And then test that food. So here I would certainly have tested the egg. And we're talking about IgE blood tests mainly because for non-allergists, they can do that blood test or a skin prick test. And then, of course, you avoid the egg. But screening tests really are best to avoid. And the problem is if you do a screening test and you start avoiding foods that the child is not allergic to, they may become allergic, and we'll mention that. And the diagnosis of food allergy is such a knock-on effect for the family. A lot longer to shop. They're now looking at foods, trying to find to avoid milk and egg, wheat, etc. A lot more expensive. They've done studies looking at quality of life scores for food allergy and diabetes, and the scores were worse for the parents of a child with food allergy compared to a child with diabetes. There's a risk of compromised nutrition. They're avoiding a food they don't need to. And of course, there's the risk of fatal reaction if they're avoiding the wrong food, which they are allergic to. It works both ways. But a highly restrictive diet imposes long-term feeding behaviors. And we see lots of children and teenagers who've had this diagnosis, and they're fussy eaters, picky eaters. So what about another case? So 9-month-old. Now, this child was given scrambled egg 3 times, and each time has had a rash on the face. What I always ask the parents when a child's having a food allergy reaction is, was the child happy? If the child's having an allergic reaction, then they're generally not happy. Even young children, they're not going to enjoy it. They're going to have sensations in their mouth, etc. And though they can't verbalize it, you can get a sense they're not enjoying it. But this child had it 3 times. Each time they had a rash, but the rash went away quickly. No other foods. Is this allergy? Well, it's not classical though, because there's just a bit of rash, there's no swelling and things like that, and the child seemed to be enjoying it. But I would do a blood test maybe just to check, or a skin prick test, and the result came back just a little bit high. So is this significant? And I'd go back to the history. The history wasn't clear. I guess here the child's eaten it several times. And certainly children can get a rash on the face from contact from various foods. So I would actually give this food to the child again, but maybe in the clinic, put some Vaseline on the face and confirm it. Now we do have, if you are doing blood tests, we do have some levels for different foods published that do give a positive predictive value of 95%, but that's dependent on the population. But we do have some guidance. And certainly if you do a blood test to a food and the level is above one of these levels, then that's fairly significant and likely allergy. But there's still going to be those ones that are inconclusive. But I think when you're interpreting, you're looking at 2 things. You're taking the history. So the history is vital. And do you have a high likelihood, medium or low? So if it's a poor history, and the test is low, then this is an allergy. If the history is very suggestive and the test is intermediate or high, then we're thinking allergy likely. But it's these yellow areas where it's not so clear cut, and we want to be careful over diagnosing. And that's where challenges are so important. And certainly, I think if you are seeing children with food allergy, interpreting results, you have to be in a position to be doing challenges as well, because it's a vital part of your tool to diagnose it. What about testing and screening? So 2-year-old child has a brother who's got peanut anaphylaxis. Mum wants to know if their child has got peanut allergy. And that's a genuine concern for them because they've seen their older child have allergy. But what can we do? The child's avoiding walnuts. Now, we want to get this right because obviously we don't want to be giving nuts if the child has allergy, but also if the child doesn't have allergy and we continue avoiding, then we are risking this child becoming allergic. And we know this child is at that increased risk because of the sibling, but the risk is still low. So there was a study looking at screening of siblings with food allergy. They took over 1,000 children. 1/3 of those children they tested had a negative test and no symptoms. But half of those children had a positive test and no symptoms. Only 13% had both. So half were having a positive test and no symptoms. So this tells us the screening's unhelpful. We don't want to test these children. We need to give it. Now, we need to support the family in finding a way of giving it that mum is feeling reassured about. I suggest they come to clinic, they can go in the cafeteria downstairs, sit in the ER. These are food that a child's never eaten before, but important that they get it in and try. Now, this is a very common scenario where we see food panel testing, eczema. So we've got 11-month-old. Scratching, red, bleeding, very difficult eczema. Mum is putting on the creams regularly, but we always have to be suspicious there. She's only using steroids for 5 days because she's afraid, because she's been told you almost always stop at 5 days, which of course is not true. And mum comes to clinic and said, right, I think it's food allergy, I want to test. Eczema is very, we talked about eczema in the talks, it's very life-changing and quality of life is very affected. But eczema is not caused by food allergy. Eczema is a skin problem. It's a skin barrier dysfunction. Main factor is filaggrin. And the more filaggrin expression that the patient has, the reduce the risk of eczema. And genetically, if they have very little filaggrin expression, they have a high risk of eczema. And eczema is dry skin, scratching, all those things. So what do I say to patients who come to me and say, I want a food test? Well, I really try to discourage it. And I explain that eczema is not allergy. It's a skin problem. And allergy tests are not helpful. When it comes to trying to find a trigger for eczema. And absolutely, I think one of the parents sometimes think, oh, if I find a food and I remove that food, the skin will be better. But as we've been talked about today, lots of things trigger your skin and you have to get the treatment right. Now, I would consider allergy tests if the parents come with a history of an acute reaction. Absolutely, that's IgE mediated. And of course, they are more at risk of having those reactions than somebody who doesn't have eczema. If they have uncontrolled eczema, sometimes if we're really pushed, but again, you know, it's down to the basic treatment because what happens is if we do the test, then we get things like this. We've got slightly positive egg, bit of sesame positive, nut mix. I mean, nut mix is, this test should not be done at all because the problem with nut mix is, okay, it's positive. You don't know what nut's the problem. So, that test should never be done, in my opinion. And orange again, and then the parents having to avoid these foods, etc. But this is probably sensitization in a child with food allergy. And we see much more sensitization with egg, milk, and peanut compared to those who don't have food allergy. And they've looked at this meta-analysis looking at whether dietary exclusions helped improve atopic eczema. And they came up to the conclusion that despite the frequent use of these exclusive diets, there's very little evidence to support it. They mentioned maybe egg in some children, but otherwise very little evidence. So I feel they're unhelpful, absolutely, and inaccurate. actually doing them. There's little evidence. I think the other problem with doing these tests, if you start saying to parents, oh, it's a food, then they start forgetting the basics of care of treatment. They need to be using the moisturizer 4 times a day, steroid for flares, etc. And there have been studies showing, looking at children who were put on these elimination diets when their child was eating food, and subsequently they developed allergy after that elimination. And Chang et al. Published in 2015 showed 19% of those patients that went on an exclusion diet subsequently developed allergy, which if they'd continued that food, they probably wouldn't have become allergic. If you do consider cutting out of food and then things get better, always remember it may be better because they changed the treatment. So do bring the food back again to confirm it. And actually, when you have eczema, the key thing for eczema in reducing food allergy is aggressive treatment of your eczema. So here, this is looking at the incidence of food allergy at 2 years of age, and age on the bottom there. And the younger the child was started aggressive treatment, this is steroids and moisturizers, the incidence of food allergy reduced because the exposure through the skin is reduced the more aggressive your treatment is. Last scenario, common intolerances. Doctor, my child has watery stools. Doctor, my child has behavior problems. Doctor, my child gets headaches. Doctor, I want an intolerance test. Again, we see lots of that going on in the UAE and Dubai, but no. And this is what they're getting, these food prints, the red, yellow, green, and high IgG, they're being told they've got food allergy or food intolerance. But actually, high levels of IgG are associated with tolerance to food. We've already been talking about rhinitis and using slit, and immunotherapy increases your IgG4 levels for those things. It's the same for food. So in fact, these tests are actually showing tolerance, not allergy. And if we restrict the diets to these children, we are increasing the risk of them becoming allergic. So IgG testing should never be done. There's never any reason for it, but it's a test that is marketed, and I guess parents like it because they have this sheet and they think, fine, but it's a very bad idea, and all the bodies are very clear on this, America, European, British Society, etc. So when it comes to doing an allergy test, this is the mnemonic I found online, but I think it's very good. So you have a patient in your clinic and you're thinking of doing a food allergy test. So the first question is there a specific food in question? If there's no specific food, they just want to test, we're not doing a test. If there is a food, do those symptoms happen every time that food is consumed? Do the symptoms happen within an hour? Do they resolve after 24 hours? Are there other symptoms other than GI symptoms? And do the symptoms include hives, flushing, anaphylaxis? And if all those things are met, that's when we should do an allergy test. So before we talk about how to interpret them, we need to be doing them in the right scenario. So I think in summary, allergy tests, obviously they are part of our management and very important. But I think as doctors, if you are going to do the allergy test, you need to be having the skills to interpret them. And never detract from doing tests to getting the basics of the treatment right if you're doing allergy tests for asthma or eczema, etc. Focus on the history, that's the most important, rather than relying on any tests. I don't do any food panels. Now, I may do, respiratory panels is different. So we're looking at dust, pets, and cockroach, allergy and asthma, very linked. I do a panel there. If you overdiagnose cockroach allergy, you weren't going to have a cockroach for a pet anyways. It's not a problem. But if you diagnose peanut allergy, that is a problem. Life-changing, risk of developing allergy for real. Do speak to allergists for support. And I think as doctors, we all want to help our patients, but we can't be expert at everything. And we do need to, speak to each other. Thanks very much.